First of all, at the outset, I would like to thank Dr. Sindura, Dr. Shamsheer, and the whole team for having me here. So I've been told to focus on the quality control in clinical practice because embryology, I think it's been going on for many years, and most of us understand. But I'll touch upon a little bit of lab and more of the clinics part of it. So what exactly is the excellence in ART? It's getting consistent. It's doing consistent, ethical, and patient-centric practice. It's an integration of science, technology, and human compassion. So human compassion, I feel, is the most important part of it, especially when you're offering a service to infertile patients. And it is not just success rates, it's ensuring safety, transparency, reliability, and constant improvement. So if you look at this feedback loop of excellence, first of all, if you're running a practice, you need to define excellence. What exactly it means for you? Does it mean getting just the pregnancy rate positives, or does it mean a continuous improvement, ethical practice, and ensuring consistent outcomes? So you have to define what it means for you. You have to design a way to ensure that you are getting what you desire, and you have to make sure that you do it consistently. So you define the processes, define the SOPs, training, validation, and then you have to measure your performance with the KPIs, and then you have to do a constant training and improvement. And at the core of it is patient safety and patient satisfaction, which is most important. So ensuring quality, it should be built into each and every step, every decision in the embryology as well as the clinical domain. So TQM is the strategic framework which makes this possible. And if I put it, TQM is the process and excellence is the product. So how do you ensure quality? What exactly is quality? It means different for different people. It's a physical attribute for some, whereas it's a qualitative characteristic for some other people. It can be imaginary, it is influenced by expectations, varies from person to person. And it does not necessarily mean superiority of a product as per the latest manufacturing guidelines, but it means it's not a luxury, but it means more of consistent, good quality, which is suited to the market it is going to serve. So it's a predictable degree of uniformity and dependability with the quality suited to the market. Now, the question is, can we measure quality? Since we have been focusing on performance indicators, yes, we can measure quality, but we have to view it in terms of different processes. If you take a cue from the manufacturing industry, we plan as per the customer demands, then we ensure a customer satisfaction, we design, develop, provide a service, and take a customer feedback. But everything has to be under a strict quality control or a strict control. And there has to be a feedback loop which helps you improve things. So if you bring in the management philosophy, we define quality management as the integration of quality services into a management philosophy. If I take you to the history of quality management, it started with Ishikawa, who transformed Japan from, they were making shoddy products, but they transformed it into a world-class electronics and other goods. So it primarily means eliminating variation and improving processes. A best example of quality control is the Dabbawalas in Mumbai. They deliver the dabbas right on time, uniformly, consistently, and they are very dependable. So the whole of Mumbai gets food because of them. So total quality management, it's absolute, it's comprehensive, and it has a distinct characteristic. And there is a management part to it, like Sindura she's managing the whole the show here. So that kind of management is needed, looking after each and everything, the administration part of it. So this ensures long-term success, and it gives a sense of teamwork, a sense of belongingness, and brings customer satisfaction. So if I look at the principles of TQMS, there has to be a leader who has to bring in a quality culture, and we should know the patients and their expectations. We have to define processes and communicate strategies to the staff and other professionals. We have to identify roles and responsibilities, identify risk and try to mitigate them, and ultimately measure performance with patient satisfaction. And this has to be a collective responsibility. So ultimately, quality management is all about defining processes and meeting patients' expectations. There is a beautiful line which says that you cannot control what you can't measure. So that is why quality is designed in a process fashion, so that we can ultimately measure quality, because quality is something which is qualitative, but it's not. We are breaking it down into small processes and trying to measure each and every process. So TQMS provides service in a standardized way. It measures results, improves constantly, and increases efficiency as well as profitability. So TQM is a simple scientific way of doing business. But is it suited to running an IVF lab or an IVF unit? Yes, because IVF, if you look at it from a manufacturing perspective, it will be a little crude for me to say, but you're manufacturing babies and you want to manufacture healthy babies. It's a set of interrelated processes which starts from clinical interaction and goes up to lab, ultimately goes up to having a healthy baby. Each process is subject to variation. And if I break it down into very small bird's eye view, it starts with consultation, diagnosis, and then we work up the patient, design treatment strategy, ovarian stimulation, then the lab comes, and then ultimately IVF outcome. And each process is subject to variation, and we want to control and minimize the variations. Another three pillars of TQM are performance management, quality management, and risk management. If you look at the performance management, we have to hire people from the right qualification. Now our ART Act 2021, it has defined the qualification, the training necessary to carry out ART. There has to be a sense of ownership in the staff, and everything has to be measured. Everything looks so repetitive, but we'll come to the main topic now very soon. Benchmarking, competence has to be defined for each and every process, and feedback surveys should be done to ensure there is no complacence. If you look at quality management, again, start with the process, QC, QA, QI. I will not go into the details of these terminologies. SOP adherence is a must, then quality audits, quality control, lab material validation, traceability of each and every gamete and each and every product it comes in contact with during its journey. Witnessing is very important from the lab perspective. Document control, root cause analysis if anything goes wrong, and troubleshooting. If you look at the risk management, we try to eliminate the risk. Like you try to store a semen sample so that you can fall back on it if there is no semen produced on the day. You try to minimize risk, like you split the gametes into different incubators. At times you have to accept the risk, because if you're triggering with HCG in an agonist cycle, then there has to be a risk of OHSS which has to be accepted and explained to the patient. And ultimately, it's all about risk management. If something goes wrong, you have to manage the risk. So in a way, it is bringing about standardization, systemization, and simplification of workflow in an IVF unit. This is a very interesting article which says that it was done by Monet et al. And they analyzed around 1700 donor cycles and did around 14,000 biopsies. And they found that the average euploidy rate ranged from 40% to 80% across different labs in donors. Donors are of the same age group, but there was a variation of around 40 to 80% euploidy rate. So they postulated that there's strong association between center-specific ART treatment processes and the incidence of euploidy. They postulated that hormonal stimulation may affect euploidy independent of embryonic number and uterine receptivity. Lower live birth rate diminishes with increasing dose of gonadotrophins irrespective of the maternal age, and differences in the donor ovarian stimulation also contribute to these euploidy rate differences. So they postulated some center-specific factors which can lead to differences in the euploidy rates. Number one, drug dosage, type and duration of ovarian stimulation. Number two, the way they're aspirating the follicles, whether they're using a double lumen needle or a single lumen needle, how long is the aspiration channel. And then some physicians have different preferences for FSH dosages and the number of eggs aimed to collect. Higher dosages may lead to poor outcomes because of poor oocyte quality. Then again, as I said, which follicles they want to aspirate, at what negative pressures, whether they want to flush or they don't want to flush, differences in time between administration and oocyte retrieval. Some other factors are whether the physician is keen on aspirating the small follicles, what is your lab quality, whether there are any contaminants, VOCs, because they can also influence the differences in aneuploidy rates. Culture conditions also can lead to post-meiotic abnormalities. So these are various factors, and there can be difference across different medias and different culture techniques. Usually the treatment is highly influenced by patient-related parameters such as age, lifestyle, BMI, etc., as well as the clinical practice of stimulation protocols, transfer policies, competence of the clinical staff, and all these things, the clinics and the lab, it's a two-way association. Embryologist clinical communication is extremely important, and it's a team effort. So we have to not only look into the lab part of it for improving the quality, we also have to look into the clinical part of it. If I break down the whole IVF workflow into a 10-pointer, it starts with consultation. The waiting time again is very important for patient satisfaction. Then the consult, the workup. Soon you can reach to a credible decision whether you actually require you require IUI, you require IVF, or you require purely counseling. Ovarian stimulation, the consents, finally egg retrieval, sperm retrieval, fertilization, embryonic development, transfer, discharging the patient, and ultimately finally the pregnancy test and the follow-up of the patient. So it all starts at the reception, where you should try to ensure a very comfortable environment for the patient, and a very standardized patient ID system has to be there. A double verification of identity, data accuracy, confidentiality has to be maintained, and everything has to be done in accordance with the PNDT Act as well as the ART Act. We should ensure that there is is no overcrowding, patients are nicely spaced out, and there is reduced waiting time. A specific counseling room has to be there. Scripted professional communication protocol is established. There, multilingual support is preferred because in our country, people like, people who speak in their own language. So if I am in Andhra Pradesh, I would like to counsel in Telugu rather than, in Hindi or Punjabi. There has to be very clear information, clear communication regarding the cost involved, the billing, a very clear communication on the injectables, their dosages, their routes of administration, etc. And ultimately, there has to be a feedback forms which have to be in place so that patients can give their opinion about the staff and the interaction, and staff also say it's compliant and they stay on their toes. The survey forms have to be there at the reception desk, and this is just an example of survey forms and their audit. Just grades the performance of the nurses, the receptionists, the parking physicians, nurses, everything has to be monitored to ensure excellence. There have to be clear information on the transport of media as well as the drugs. Their storage, SOPs have to be there, dedicated refrigerator, not like a usual refrigerator should be used, and there has to be a temperature probe monitoring the fridge which is storing the drugs as well as the media and oil. The batch number of drug should be mentioned and clearly documented. Their expiry, timing of injection, and patient education should be there. We have recorded small video demonstrations of how to administer the injections. So, patients can monitor the injections even if they're not doing it on their own, even if a nurse is coming and doing it, if they're doing it at their houses. So they have some idea about the right technique. There should be a standardized workup of the patients, like AMH, semen analysis, and karyotype, etc., if it is needed. And there has to be a clear-cut protocol, what investigations are needed for the wife and their husband. Unfortunately, husband is the most ignored partner in the whole, or the male partner, as I can say, is usually the most ignored partner usually. But a standardized protocol for examining the male, taking a proper history, doing semen analysis, and ultimately deciding what other investigations such as sperm function test, endocrine evaluation, or a genetic test is if at all it is needed, has to be in place. A policy has to be in place. If you, when the patient comes and interacts with the clinician, there has to be a proper individualized stimulation protocol. Don't do a cut-paste job because that will lead to errors. Always review past cycle details and check the doses and ensure that the sisters or the nurses are administering the right medications at the right time. Educate patients of self-injection and monitor compliance. When the patient is coming for ultrasound, make sure that the same person is doing the scans over and over again, and different physicians are not doing, because everybody documents and interprets in a different way. And when you are doing patient counseling, especially the sensitive part of it, always try to do a video recording and document and sign on the sheet. There should be a proper risk counseling, such as regarding the chances of multiple pregnancy, genetic risk, as well as OHSs. Do go through this latest ovarian stimulation protocol by ESHRE, released this year only. This says that the efficacy is determined by cumulative live birth rate as well as the live birth rate. Also, the efficacy is shown in the number of M2s you are getting. That is the oocyte maturation ratio. Safety is determined by the incidence of OHSs. But CLBR is a very long-term indicator. It takes around 1 year to calculate CLBR. So we rely on other indicators for clinics and not CLBR and LBR. LBR might be subject to loss of patients because they may not come back and report the pregnancies to you. Documentation has to be very crisp and clear, and we should ensure completeness of patient history, examination, treatment plans, and everything has to be documented in a soft copy in the software as well as on the piece of paper. Another thing I would like to say, because this has been questioned from us in various JCI and NABH protocols, they always ask for documentation on discard of embryos and gametes. So maintain a register and get it signed by the physician as well as by the patient when you're discarding the embryos. Now Dr. Hitesh is here, so I will not like to go into the details, but you can take a picture if you want. This is the list of documents which we require for IVF with self gametes. This is list of documents which you need to ensure with IVF with donor oocytes. And this is the workflow for surrogacy, all the documents and the plan. Now I'm skipping this. Now we are coming directly to the QC in IVF OT. You should maintain a proper temperature in the OT. It should be around 24-25 degrees with the right humidity, 40 to 45% relative humidity. All the equipment should be nicely ready and calibrated. You should always believe that each egg counts, and there should be a complete OT checklist ensuring asepsis, all markers should be negative. Anesthesia should be, given properly and safely. Double verification of patient ID, verify trigger timings before, inducing the patient, and verify all the consents are in place. Temperature of OT, lab, test tube warmers and media should be maintained at 37 degrees or 38 degrees. All the records regarding expected follicle count, the actual oocyte yield, and other complications, if there are any, should be documented. And very important here is embryologist clinical communication. Both should be in sync, what to expect and how much time it takes, and what the plan is for the future. I would just like to, educate you on the tools, because I've seen that not many people are aware of this. We have got a single lumen and a double lumen needle. Then the gauge which is preferred is 17 gauge or 18 gauge. And there is a needle with edging and a translucent tubing, which is the aspiration line. If you look at this picture, this is the needle. The length of the needle varies between 30 and 35 centimeter, and length of the aspiration line, it all varies between 30 centimeter, 60 centimeter and 90 centimeter. 60 and 90 centimeters. So always prefer a needle 17 gauge. 30 centimeter should be the length of the needle, and 60 centimeter should be the length of the aspiration line, because the more you expose it outside, the more temperature changes and more incidence of aneuploidy. So this is one of the reasons why there was a huge difference between different centers, along with the protocols, venous stimulation protocols. This is what I was telling you earlier. So the bevel is a B type bevel, which is used for normal patients, whereas the A type bevel is used for smaller follicles. This is the aspiration line which we were mentioning. This has to be 30 centimeter. You can always bring in the table a little closer where the pump is being kept. There are also needles which are available with 35 centimeter needle length and 90 centimeter. Imagine 90 centimeter, people are still buying it. I have seen people buying 90 centimeter, and I've tried to educate them that please go for shorter lengths of needle as well as aspiration lines. So this particular study published in 2005, it says that the temperature of follicular fluid dropped by almost 8 degrees during aspiration, and the dissolved oxygen level also rose by 5 plus minus 2%. The pH changed by almost 0.1. So you have to maintain proper quick work and proper temperature. See, this study by Wang et al., they said that spindle density goes on changing with every small drop of temperature, and it may or may not recover depending on the length of exposure as well as the duration of exposure and the rapidity of exposure. If you quickly drop from 37 degree to 20 degree, even a 1 minute exposure might be detrimental to the ultimate oocyte embryo quality. The quality here we are analyzing in terms of the aneuploidies. Another tool which we most commonly use is the aspiration pump. Now, how many of us are calibrating the aspiration pump? Well, you can do it sitting back in your own lab. So even ASHRAE says that there is no consensus on the optimal oocyte aspiration pressure, and some people recommend from 100 to 150 to 200. There are many different thoughts. The suction pump should be validated prior to use, and a spare suction pump should always be present. This is as per the ASHRAE guidelines. So our target is to optimally aspirate the oocyte, and the main thing you have to look in an aspiration pump is you have to establish the right flow rate. That is the speed of aspiration of follicular fluid. So is there an optimal flow rate? Yes, it ranges between 0.4 to 0.5 milliliter per second. And if you look at a 17 gauge needle with an aspiration pump set at 100 milligrams, 60 centimeter aspiration line, then you should be able to aspirate 12 ml of water if you're just trying it out using water in 30 seconds, or 24 ml water in 1 minute. So I'll just show you a video how to do it. So you take some water in a beaker and aspirate fluid in a test tube, and after 30 seconds you see that 12 ml of water has come in the test tube. So that is establishing the correct flow rate. The flow rate also depends on needle gauge, or what gauge needle you are using, needle length, diameter of the connecting tube. If you're using a smaller gauge, you have to increase the pressure. Not many do it. If you're using a longer length of the needle, again increase the pressure. Length of tubing, longer tubing, increase the pressure. Dual lumen, increase the pressure. So not many companies have documented this, but Kitazato has documented this. Every reduction in the gauge, the pressure almost goes up to 150, then 175 almost. If you're using a 20 gauge needle, the pressure goes to 200 millimeter of mercury. And here, if you're using a double gauge, the same 17 gauge needle, you have to use as 175 plus minus 5 pressure. How many of us do it? Practically nobody. Very few people use double lumen nowadays, but if you're using, you use it the right way. Most important is embryo transfer. You have to be a proper embryologist clinical communication even before you start the process. How many embryos to be transferred, which embryos to be transferred, you're doing a preloading, you're doing an afterloading. Everything has to be discussed beforehand. Time out, calling out the name loud, double witnessing of embryo identity and quality. Speed of injection again is very important. Who pushes and at what speed has to be decided. Rotate, withdraw, immediately come out. If there are retained embryos, you have to retransfer. So all these steps are very important. And a mock embryo transfer, as I was discussing with Dr. Sindhura, she does a lot of mock embryo transfers, and most of us do mock embryo transfers to ensure that there's a smooth transfer procedure. This is a very recent article published this year into Human Reproduction. The ART-ET screening tool, it is able to predict difficult transfers based on ultrasound findings. So do read this paper. Again, we have to counsel the patient about chances of OHSS, bleeding, infection, and we have to do complication audits and incident reporting also. If you look at the QC in lab, temperature, again the same parameters, temperature plus 37 plus minus 0.5 is acceptable. Pressure, their lab has to be at a higher positive pressure compared to the OT. 15 to 16 air changes per hour, 45 to 50% of relative humidity. VOC is as low as less than 2 parts per million are preferred. Particulates again, class 10,000 is preferred if you're talking about the ambient atmosphere. And this is a tool which helps us, check things from our mobile phone. You can quickly see what's going on in the lab. And you do get phone calls and other messages, SMS messages, if anything goes wrong. If you are looking about the microenvironment or the culture environment, you have to check the temperature of the laminar, temperature of the heating blocks, incubator every day. You have to look at the gas composition, oxygen, CO2, pH every day. Osmolality of the media has to be documented. Again, daily calibration of microscopes, micromanipulation, and incubators has to be done. And you need to have alarm systems to check all this. And like we have acquired this one from one of the companies, and we can monitor it from a distance. We can do it physically also. And all the media, their expiry date, their batch numbers, their lot numbers has to be documented so that there's a good traceability in case anything goes wrong. Minimal temperature and pH fluctuations during gamete handling is extremely important. We have to ensure the right SOP adherence, strict timelines, double witnessing or electronic witnessing, whichever is your method of choice. You have to keep a count of number of oocytes you are picking up, you are keeping them back. So everything has to be counted, and it's like a chartered accountant. You have to work in the lab, with that kind of precision. All the warming survival audits have to be done. Immediate documentation of embryos is preferred. These are again examples of alarm systems set up on the cryo lab, and you can simply maintain who is doing the procedure, who is witnessing. All the procedures you can jot down. You have to be adherent to the legislation, and you have to continue the learning at the same time. It's just an example of the KPI charts or the graphs which are being done every month. These are the embryology indicators, so I'm going to skip them. So there are some challenges in clinical practice. We will ignore that. It's about training and legislation. But there are clinical KPIs which have been defined, and if the clinical KPIs and the lab KPIs are good and the results are poor, then there is a difficulty in ET and associated pathologies. Clinical KPIs are, on the higher side, lab KPIs are low, then can be embryologist's fault. Clinical KPIs are low and the lab KPIs are good, then you have to appreciate the embryologist. And there is this Maribor consensus which came out with the stimulation and parameters judging the clinical practice. It has two indicators to judge the ovarian stimulation, that is the cycle cancellation rate and the number of cycles with OHSs. And then it has got for monitoring the ovarian stimulation trigger and OPU. There are two indicators again, the ratio of M2 oocytes as well as the complication rate. And assessing the effectiveness of embryo transfer, it has got clinical pregnancy rate and multiple pregnancy rate. But this has some pitfalls. It does comment on the the training and the proficiency levels, but it has got some pitfalls. I'll just run through this. For clinical pregnancy rate, it has not defined the denominator. So either it can be per initiated cycle, which will give a different outcome, per OPU, again a different outcome, or per embryo transfer. So there were some drawbacks with this. So another group came out with another set of KPIs for clinical practice, KPIs, PIs, and RIs also. I'll just share this, probably will be one of the last slides. So the indicators for ovarian stimulation performance are cycle cancellation rate and follicle to oocyte rate. If you look at the efficacy of ovarian stimulation, you have to look at the proportion of M2 oocytes at the end after retrieval. For assessing the clinician performance, it's a complication rate. Assessing the patient performance, again, the embryonic development rate. If you look at the operator and gamete competence, we have got it's a mix of clinical and lab KPIs. Then you have got the fertilization rates. If you look at purely lab performance, we have got proportion of top embryos on day 3 and day 5. If you look at the luteal phase, then you have to see the rate of multiple pregnancy and miscarriage rates. So these are the indicators. They have defined what exactly they are looking into, and they have designed the cutoff values, the competence, the benchmark. And I really recommend all the clinicians to adopt this practice and start monitoring the clinical work. Again, the clinician performance is assessed on the rate of OHSs, which is practically negligible nowadays, and clinics do advertise as zero OHSs clinics. And they have got 7 PIs also, which will not go into the detail. Another aspect of high quality IVF center is number of satisfied patients who come back. So for that, you have to patient education, right nurses, counselors, patient stress management, effective communication, at times hand-holding, doing surveys and feedbacks on staff. So these are the important factors which bring patients back. They have to, feel comfortable. And so these are the set of 7 performance indicators which the group mentioned. It's an Italian group. I told you about satisfied customers who return for a new cycle. Ultimately, you have to make their journey very smooth, as shown in the figure. Nowadays, a lot of AI is coming. That is the future, and AI can help us, achieve the workflow optimization. It can help us choose gametes, embryos. The quality control and KPI monitoring can be done with the help of API. So in the end, I would about several T's, which the right treatment, techniques, tools, instruments as I showed you, right documentation, testimonials, team training again, transparency, traceability, test, that is the KPI and audits, troubleshooting if there is anything which is going wrong in the lab or the OT, using the right technology like adopting more and more of AI and other new techniques. Again, the patients coming back who want to try again. So these all are the marker of your clinical excellence and satisfactory performance. So I would like to summarize by saying that excellence is a result of total quality management. It integrates people, processes, and purpose with a lot of compassion. It has to align with the local legislation, and individual clinics should actually, review the indicators, and they should decide which they can easily calculate, which suits them, and they should monitor those KPIs. When quality becomes everyone's responsibility, excellence becomes inevitable, and nothing better than working in a team where each member complements the other for success. I've worked in one such lab, and I think I'm privileged to work in that kind of atmosphere where, the clinician says, embryologist, he tells that you've done it, and you tell the clinician that you have done it, and the whole staff also feels, a feel-good factor and sense of ownership. Thank you so much.